Greetings, aspiring orthopedic clinical specialist. We are going to review our cervical case here today. So if we read the case, what I'm going to do is we're going to go over the case and I'm going to point out some important pieces of information that you should be aware of as you read through the case and you should highlight. And then we'll go over each of the questions and talk about the correct answer and the incorrect answers. So right off the bat, we have a cervical case, a 50-year-old male. Typically, when you're given an age and or a gender, those are typically important to the question. So I want to pay attention that this is a 50-year-old male that is coming in with this issue of neck pain. So that's the first thing that I would highlight or make note of. And we have a chief complaint of neck pain and stiffness. So we're gonna make note of that as well. That's why they're coming in. And we're told about 2 weeks ago without a known mechanism of injury. So insidious onset about 2 weeks. So we're thinking it's more acute versus chronic. And then we have reports of their pain. They talk about a dull ache. That's obviously important. The intensity, 2 to 6 out of 10. So that's obviously important for us as well, so that we know how intense this pain is. They talk about radiation to the right shoulder and down the arm, and intermittent numbness in the right hand, particularly that thumb and the index finger. So we should be thinking about peripheral nerves that would refer to that region, nerve roots that would refer to that region. So we start going through that differential diagnosis process in our head as we read this. And then we learn that we have an occasional history of headaches. That makes sense with some cervical spine pain. So that's nothing that's abnormal right now. And they're described mostly as pressure. And then we say over the past 2 weeks, the headaches have been more consistent. So they haven't changed. They've just been a little more consistent. So that's something I would pay attention to as well. And then we have good information here about what aggravates our symptoms. That's obviously something we're always interested in. So they're aggravated with neck movement in all directions. So it's not like it's flexion biased or extension biased. All neck movement hurts, and sustained sitting at work. So imagine that if we're sitting, we're probably in this forward head posture. They become worse as the day progresses. Again, these are kind of normal complaints that we hear with patients with cervical spine pain. And they deny any trauma, no history of cancer, no weight loss or night pain. So obviously they're giving us information about potential red flags. So right now we should be thinking that this is fairly musculoskeletal-ish, and we should have some ideas about conditions, diagnoses that we're thinking of. And then we learn that we have a history of hypertension. So that should make our spidey sense tingle a little bit, and smoking. And then we're given information about they tried to quit smoking and how much they're smoking now. And it limits exercise tolerance, occasional shortness in the breath, walking uphill, and those kind of things I think make sense with that past medical history. They've had x-rays, which showed some degeneration. Again, we're 50 years old, so that probably makes some sense. And they wanted an MRI, but the patient declined due to financial restraints. So that kind of sums up our case. And I've given you the kind of pressure points that I would look at in that case and things I would highlight that are probably going to help me answer some questions here. And then we're given some information about the physical exam now. So we have a slight forward head posture, probably expected from what we read. And then we're given some range of motion measurements, and it looks like they're limited in all directions. So it doesn't look like one direction is more limited than another direction. And then we're given our neuro exam. So we have 5 out of 5 strength in both upper extremities. So that's pretty good. We have decreased light touch sensation in that C6 distribution, which we probably glean from our history as well. And our reflexes are normal. So our hard neuroscience are non-existent, basically, is what we're saying. And then we're given some palpation information here. So when we palpate that upper trap on the right side, it reproduces the headache. So we start maybe thinking cervicogenic type headaches. And then we have joint accessory motion testing. When there's pressure on the right side, we note hypomobility, and it also reproduces some of the hand sensation issues. We're given information about the flexion rotation test. It was normal and symmetrical, and it did not reproduce the headache. So again, that gives us information about this headache and its possible connection or not its connection to cervical spine pain. And then we have C0, C1, unilateral pressures, that they were normal and they did not reproduce the headache. So now we're thinking a little more away from that cervical, that potential cervicogenic headache. And then we're given, last piece, upper limb tension test of the median nerve was negative. So that also gives us some information here that we're not thinking maybe a peripheral nerve or anything like that. So that sums up the objective information that we're given. And now we get to our questions. Our first question, based on what we're given, what's the most likely diagnosis? And we look at our choices, and they're all plausible, but the correct answer is going to be B, neck pain with radiating pain without radiculopathy. If we look at the incorrect choices. The distractors. Our first choice, C6 radiculopathy. Our neuro exam is normal. So that gets us away from the radiculopathy piece. So that's why A would be incorrect. That's why the C6 radiculopathy wouldn't be correct. And we talk about neck pain with headaches. We do have headaches here, but physical testing of the cervical spine did not reproduce those headaches. So we have headaches, but they're not the primary symptom, and they're reproduced with palpation of the cervical spine, not so much with motion of the cervical spine. So that's a plausible choice, but it's not the best choice. And then choice D, adverse median nerve neurodynamics. Our upper limb tension test was negative, so that gets us away from that choice. So our best choice here is neck pain, which we obviously have, with radiating pain without radiculopathy. This patient has radiating pain down their upper extremity, but we don't have radiculopathy symptoms because our neuroscience, reflexes, sensation testing were normal. So that's why we have our best answer was B. We look at our second question, most appropriate initial treatment. So we have an idea of what we think the diagnosis is for this patient, and now we're asked about treatment. So we look at our choices. Our correct answer is going to be A, exercises to mobilize and stabilize the cervical spine. Why are other choices incorrect? Thoracic joint mobilization. The thoracic spine is linked to cervical spine dysfunction, but most of the evidence talks about thoracic spine manipulation being effective for cervical spine issues. And this choice is thoracic spine joint mobilization. So that's maybe not the best choice, even though maybe that's splitting hairs, but we're also not given any information about thoracic spine limitation and or palpation of thoracic spine reproducing the cervical spine symptoms. Everything that we were given was palpation of the cervical spine or tissues around the cervical spine reproduced the neck pain and or headache. So that's why that thoracic joint choice is not the best choice. Mechanical traction. This is an acute case. Mechanical traction has been shown to be better for more chronic cases of neck pain. And this is only 2 weeks. So that's why we want to pay attention to how long this patient has had symptoms. So that is not the best choice. And choice D, no treatment, that they need to be referred out to get that cervical MRI before we're going to treat. There's nothing in their presentation that makes us think that there are any red flags present or anything that's not musculoskeletal in nature that we could not treat this patient effectively. So that is not the best choice. This information is coming from the neck pain clinical practice guidelines. Clinical practice guidelines provide a wealth of information for these type of questions in terms of interventions. What is the most efficacious intervention? What is the most likely diagnosis? So all that information is contained in those clinical practice guidelines. So that takes us through our diagnosis and our initial treatment question. Now we're given our third question, and now we're told that the patient comes back in 2 weeks. So treated the patient perhaps. Now they come back for a follow-up in 2 weeks. Now they tell us they've done their home program, so that's awesome, and they have some improvement of their symptoms. But they said as their symptoms improved, they went back to their chiropractor. And they received, and they've been working, we're given the information that they've been working with the chiropractor for years. So this is not a new visit or a new practitioner involved in this person's case. And they have a long history of receiving cervical spine manipulation from the chiropractor. And they had that 2 days ago is what we're told. But now this patient is telling us, I don't feel right. And normally they said those manipulations give me relief, but this time they didn't. And they also report having a different type of headache, a different kind of headache than the headache that had been reported in our initial information. They talk that it's more intense and it's lingering a lot more. They also report feeling really run down. And they said, you know what, I tried sleeping a lot more. Maybe I thought I was tired. And that didn't seem to work. And now we're asked the appropriate plan of care at this time. So now we have a lot more information that we have to deal with here. Our correct choice is C. Refer this patient to the ER for assessment of a possible vascular incident. We have to pay attention to the past medical history. Remember, the person is 50, not that that's old, but the person is 50, not 20. And they have a history of hypertension and they have a history of smoking. And now they've had this cervical spine manipulation that has led to increased symptom or different symptoms, I should say, and some red flag symptoms. So this is someone that we definitely don't want to treat. So based on those factors, that past medical history and that age and their new reports of symptoms, the best option for us is to refer this patient to the ER. When we look at the other options, continue with the plan of care while monitoring vitals. Monitoring vitals is never a bad thing to do with any of our patients in any setting. So of course we would want to monitor vitals, but continuing with the plan of care is not ideal. This person needs to be referred out. So that's why A is incorrect. Continuing to perform high velocity, low amplitude to the cervical spine is not smart either. This person had a manipulation done and it gave them very, very adverse effects. So this would not be wise to continue with that vein of treatment or in that direction of treatment. And then our last choice, add an addition of aerobic training. Aerobic training is never a bad thing in most cases, especially when we're dealing with musculoskeletal pain. But in this case, if we added any type of aerobic training, that would stress the cardiovascular system, and we should be suspecting that this patient is having a cardiovascular issue. So we wouldn't want to do that. So our best choices here is to refer this patient to the ER because they might be having a possible vascular incident. So hopefully that gave you some insight into the case and how you should approach reading the case and what information is important and how you should put it together. And then how you approach these questions. When you approach the questions, you want to look for the best answer. It doesn't mean that other answers might not be plausible, but there's an answer that's the best answer and the other three are not the best answers. And you want to use that information from the case to be able to put that together to get to the best answer. So hopefully this helped us go through some of these questions and this case for the cervical spine.